Good evening, everyone present here. So, sir, you can start sharing your PPT. We'll be starting now. So, as per the topic for today is environment hazards and toxicology, and it will be
हमारे जो लैब का एक छोटा फॉर्म रहता है
Dr. Swarnendu Dey.
उसको बंदा होनी चाहिए।
Hi, can you hear me?
Yes, sir, you're audible. Uh,
Okay.
Aspirants, he is a anesthetic registrar at NHS.
Right. Are my slides visible to you?
Yes, sir.
Okay. Does it say environmental hazards and toxicity? Toxicology. Yeah. All right. Just give me a thumbs up if you can, if I'm audible and my slides are visible to you, please. Okay. So I'm all right to start then. Yeah. Fine. Good evening, everyone. I'm Swarnendu Dey. I am originally from India, where I've done my MBBS and MD in anesthesia from. Then I moved to the UK, and I'm currently working as a registrar in anesthesia and intensive care in the NHS. A bit of a disclaimer: this is for the EDIC preparation, but I haven't taken the EDIC. I've instead done the FICM, which is the Faculty of Intensive Care Medicine in the UK examination. But I believe the syllabus for both these exams are very similar, which I've confirmed with Fars Academy, and which is why they're happy for me to go ahead and take these lessons. So the topic to cover for today is environmental hazards and toxicology. This is quite a big topic, and my presentation has more than 100 slides actually. So I've decided to divide it into two classes. So the first lecture is today, and each class will be around 45 minutes or so. And so in the second lecture, I'll confirm the date later on. I will do the rest of the topic along with some multiple choice questions as well. So starting with, so what exactly I'm going to cover. So firstly, I'll cover environmental poisons, and then toxicology, which will be subdivided into following topics: overview of poisoning, psychiatric medication, recreational drugs, serotonin syndrome, cardiovascular medications, local anesthetic systemic toxicity, paracetamol, and salicylate toxicity. And lastly, very briefly, about propofol infusion syndrome and TURP syndrome. So that's the broad overall topics for the sessions, but I'm going to, like I said, I'm going to divide it into two classes of 45 minutes each. Now, starting with environmental toxins, the corrosive ingestion is relevant to critical care. I'll divide it into the following topics. There's of course corrosive ingestion, which is relevant to critical care: acute heavy metal ingestion, chemical agents, biological agents, and acute radiation syndrome. Now, what is the difference between poisoning and envenomation? It's basically in the difference in mode of entry. Poison enters via ingestion or topical absorption, whereas envenomation occurs due to contact with animals, example, spiders, snakes, insects, jellyfish, and effects are due to the neurotoxin activity, rhabdomyolysis, and anticoagulation. The basics of management is pretty much the same. It's prompt recognition, investigation, and supportive care, and application of pressure, which leading to immobilization by first aid bandage, because most of the venom remains subcutaneous. Antivenom administration, need hemodynamic support because cardiovascular collapse is likely with antivenom. Transfusion, because a lot of the times hemorrhage and coagulopathy can be seen as well during these envenomation episodes. Good pain relief and antibiotic and tetanus prophylaxis as well. Now, corrosive agents relevant to critical care are typically readily available household items And they're potentially life-threatening because they lead to airway compromise, GI perforation, specific effects, for example, GI stricture, perforation, shock, mediastinitis, and multi-organ failure. Specific care, firstly, decontamination with oral rinse only, avoidance of blind GI procedures, early airway intervention, endoscopy, and surgery. Now, coming to the next topic, which is heavy metal poisoning. I'll start with iron, which is quite a commonly available item in household. Accidental ingestion is the most common way of presentation, which leads to free radical production, and it also impairs mitochondrial function. Clinical features include typically GI symptoms like nausea and vomiting, diarrhea, hematemesis. This is followed by an asymptomatic phase. However, severe toxicity, which can result from ingestion of very heavy doses of iron, leads to myocardial depression because of direct cardiac toxicity, vasodilatation, hypovolemia, coagulopathy, and hepatotoxicity, which may lead to necrosis or cirrhosis. Other heavy metals include lead. Lead can have acute and chronic manifestations, envenomation with lead. So acute lead encephalopathy, acute envenomation leads to lead encephalopathy and cardiovascular collapse, whereas chronic exposure, mostly from water source, leads to neuromuscular dysfunction and multi-organ failure. The treatment is gastric decontamination and IV or oral chelating agents. I'll come to the chelating agents a bit later on. Arsenic typically presents with hypersalivation or garlic odor, may lead to encephalopathy, seizures, myopathy, bone marrow failure, and ascending peripheral neuropathy. Now, specific management of the heavy metal poisoning. So, specific management include X-ray imaging. Sometimes you need to do serial imaging as well to ensure complete elimination. Prokinetics, again, to ensure gut movement and elimination. Endoscopy may also be needed at times. Iron, specifically for iron, there's chelation with the desferrioxamine. Typical dose is 50 milligram per kilo over 12 to 24 hours. If serum iron is greater than 90 millimoles per liter, but one has to be careful about because it may cause an anaphylactic reaction. And arsenic chelation with succimer, which is dimercaptosuccinic acid or DMSA or dimercaprol. And finally, surgery may also be needed if in case the substance is not being eliminated from the body. Chemical weapons relevant to critical care, which is the next topic. Now, they can be weaponized or non-weaponized. They can be classified as damaging, which is impact on resources, for example, mustard gas, low-dose radiation, or incapacitating, which is temporary inability to function, or lethal, for example, cyanide, nerve gases, phosgene, anthrax, etc. Now, nerve agents, for example, rapid-acting organophosphorus, irreversibly bind to the anticholinesterase, for example, sarin, which is a typical nerve agent, and which leads to cholinergic, which is muscarinic and nicotinic toxidrome. Now, toxidrome is what is toxidrome? It's a collection of signs and symptoms which typically occur with poisoning. I'll discuss toxidromes later in my talk. But chemical weapons like sarin, which is a nerve agent, typically presents with cholinergic toxidrome. And the management is antagonistic anticholinergic medications, for example, atropine infusion. Right? And the specific treatment is cholinesterase reactivators, for example, pralidoxime and obidoxime.